Matt, thanks for a great talk on BTK solutions. It's an incredible topic, and it's a difficult task to cover in such a short time. I wanted to ask you some basic questions that are burning in the field, and then get to our panel quickly. With respect to the BTK segment, what do you view as the single biggest challenge?
I think the runoff distally is probably the biggest challenge, in maintaining patency in small vessels below the insertion of the gastrocnemius, and maintaining a perfusion pressure head into the foot and to the wound bed is probably the biggest challenge. So hopefully we'll continue to have evolving technologies that allow us to maintain patency as well as improve the perfusion head to the foot. That's probably the biggest challenge I see.
So a question that, generally BTK is synonymous with critical limb ischemia. And I think there remains controversy about the optimal revascularization strategy. I wanted to ask our surgical partner on the call, Karim Harth. Karim, for BTK intervention, what is your decision-making algorithm? There's new global guidelines that have been issued now for a year or two that are, dictated largely by surgical societies, and there's ongoing randomized trials that are awaiting readout. What do you do in your clinical practice?
So I think for me, the biggest thing is do we have single vessel runoff? Is that in terms of the below-knee level disease, is the runoff something that's easily accessible, heavily calcified? Not every outflow vessel is a good bypass target. And it's hard to do a bypass when you have no outflow in the foot. So I think those things are important when I look at someone who has below the knee disease, and I'm going to decide on whether I'm going to approach it surgically or if I'm going to approach it via a more aggressive endovascular approach. Certainly with, I think when you have heavy pedal disease, that creates a whole slew of new problems and challenges with limb salvage. So I think those are the things I consider when I'm trying to decide, is this someone I'm going to bypass an endo? And obviously there's clinical considerations. A lot of our CLI patients have multiple comorbidities. They're not going to tolerate a long leg bypass. And so those things I keep in mind in terms of my practice and how I treat my patients.
Sahil, you're mute. Sorry.
Sorry, Tomas, in Europe, do you guys rely on scaffolds below the knee, or is it more balloon-based strategies? And I'd love to get your insights on the drug delivery controversy below the knee. Is paclitaxel the right drug, and are we studying the right technologies?
Yeah, well, your first question regarding, I believe in scaffolds. So for short lesions, drug-eluting stents are my standard of care in tibial lesions. For longer lesions, in the meantime, there is data available for DCB coming from China. 2 studies have shown that the Lighthouse balloon is effective below the knee, one from Italy, one from China itself. And that's the reason why in long lesions, 20 centimeters plus, we are using this particular balloon in almost every situation, and it looks very promising. So I believe paclitaxel does work below the knee, but you need to have the right coating.
Very helpful. In terms of the scaffolding question, I think many of us are involved in investigation, but have been using coronary drug-eluting stents off-label for some time. As a PI of the LIFE BTK study, I'm particularly interested to get perspectives. Subhash, you know the data better than anybody. Tell me if you have an algorithm for when to pull the trigger and use a coronary DES. And then I want to ask Rob the same question, because he's had a lot of experience with these below the knee.
To be honest, my algorithm, what we have already published, has actually changed a little bit over the last years. And I brought up the shockwave issue intentionally, because the the challenge I face most frequently, I would not say most intensely, is the issue of diffuse disease in below the knee vessels. I cannot commit myself to a focal area of treatment. And generally, the treatment area extends beyond what I had initially planned. And that's what causes most of the challenges that I face in routinely. I'm not making exceptional cases. But I think that given the calcium solution through shockwave to be used in below the knee vessels, I think has changed my practice. Because I see fewer dissections, I'm more liberal with treatment of more diffuse, longer segments, and then not have to worry about bailout with a coronary drug-eluting stent. I think that's fundamentally my approach right now. So we are actually planning a new publication from XLPAD to highlight that strategy. And that is exactly why I asked that question during the previous session regarding selections of various tools, including shockwave in below the knee locations.
So Rob, you have a lot of experience with coronary DES below the knee. You want to share some of your?
Yeah, sure. So I'm going to echo what Subhash has said. I've not moved over to shockwave yet. I think we're still using coronary DES for bailout. Plain balloon angioplasty is the default strategy. We're not heavy into atherectomy unless there's very diffuse disease. As everybody knows, there's a lot of prospective randomized data that shows that coronary DES, including paclitaxel DES, works for short below knee lesions. There's not a lot of data about long lesions. We presented at Link and at ICIT earlier this year, our long lesion subset where we were putting in 3 stacked coronary everolimus eluting stents. Mean lesion length was about 10 centimeters in length, and we actually had incredible limb salvage for Rutherford 4 and 5 disease. The problem is, and I think Karam alluded to this before, is that this really doesn't work for Rutherford 6 disease, which in my opinion tends to be patients with nothing below the ankle. So I think, anecdotally, this is obviously just my own experience or my center's experience. I think coronary DES does have a role. I love it for bailout. We have long-term follow-up in a lot of these cases. It works very, very well. I'm not comfortable using it as primary therapy for long lesions. I'm a little bit more bullish about scaffolds below the knee than perhaps some other people. We've obviously been struggling with paclitaxel-coated balloons below the knee for years now. And so again, for bailout, I'm using it fairly liberally.
That's great. And then I wanted to sort of close this part of the discussion and ask Chris. Chris, do you have concerns about people who are attempting retrograde tibial access, or are you using it routinely in your practice? Here in New York, we have practices that run the full spectrum of 100% tibiopedal access to never doing tibiopedal access. The truth is probably somewhere in between. What's your mix, and how do you use it?
So good question, CEO. I think it's a common sense approach. First of all, I think if you do it correctly and stay with small equipment, we do not put sheaths in routinely. So we usually will go bareback with an 018 quick cross and a 018 wire, 014 wire, and then cross and externalize and work from antegrade. I think if you do that carefully, the risk of tibial access is low. That said, you still want to look at, what are you treating and how much you need to treat. So we will do tibial access for claudicants if it's really claudicant. We've worked hard. We can't get there from above. And even if they don't have tissue loss, I think there's nothing wrong with going retrograde as long as you do it carefully, responsibly. And we actually get it out pretty soon. So we will use tibial access relatively routinely. As we go into the cost era that Manesh had gotten to, instead of using a reentry device, it's a lot cheaper to go tibial. Andre Tomas have been doing that for years. And I'm not quite there. If it's so close, I'll still use a reentry, but we may even move towards that. So I think it depends on what you're treating. You do it carefully. You don't harm that tibial vessel, and you take a look at it when you're done. And then other than that, I don't have a problem with going tibial.